Great. Thank you very much, colleagues. Good morning, good afternoon from where we are. I'm excited to be here this morning, this afternoon, and on behalf of the organizing team and the Center for HIV and Infectious Diseases, supported by the Immunization Center, I'd like to welcome you all to this exciting webinar where we are discussing the malaria vaccine. And the title of our webinar this morning, this afternoon is What Works? A New Era in Malaria Prevention. We have a very strong team that's going to be taking us through some of the presentations this morning, this afternoon. And I would like to welcome our panelists, starting with Dr. Stephen Sosler, who is the head of vaccine programs for Gavi, the Vaccine Alliance based in Geneva, Switzerland. And Stephen is an infectious disease epidemiologist whose role at Gavi is to provide expertise and leadership across Gavi's routine and stockpiled vaccines supported by the Alliance that covers over 20 infectious diseases. Stephen has led the design and implementation of the new malaria vaccine program since the board decision to open a vaccine funding window in December 2021. Before joining Gavi in 2012, Dr. Sosler held key positions at the U.S. Centers for Disease Control and Prevention, seconded to the World Health Organization as the Deputy Project Manager for India's National Polio Surveillance Project. Stephen was coordinating immunization strengthening, measles control, and new vaccine introduction activities. Before Stephen went to India, he was seconded as a CDC epidemiologist to the WHO Central Africa Intercountry Support Team in Libreville, Gabon, where he served as the Accelerated Disease Control Officer, providing technical assistance to the 11 Central African National Immunization Programs, WHO and UNICEF country offices, to strengthen immunization delivery, vaccine preventable disease surveillance, and outbreak response activities. Dr. Sosler has a PhD and a Master of Public Health in International Health and Epidemiology from the Tulane University School of Public Health and Tropical Medicine. Steve will be setting the stage for this webinar, addressing why we are talking about malaria vaccines now. Stephen, it is my pleasure to invite you to set the stage for us. And for now, I'll give you about 5 or so minutes and, taking us through this initial presentation on why we are talking about malaria vaccines now. Over to you, Steve.
Great. Thank you, Benjamin. Good morning, good afternoon, colleagues and friends. First, let me thank the organizers for inviting me to open today's session. I'm really grateful for the opportunity to try to set the stage for what should be some really insightful and interesting presentations from some of the MVIP countries. Since WHO's recommendation for the wide public health use of the first licensed malaria vaccine in October 2021, and the Gavi board approval to open a funding window for malaria vaccines that occurred shortly after, the Alliance and extended partners have been working at pace to design and stand up the first malaria vaccine program. While, yes, this vaccine program is similar to other programs, it's also unique in a number of ways that need to be considered. When we started to design the program, we weren't, of course, starting from scratch. We weren't starting from zero. We had the extreme benefit of having the experiences from the MVIP projects, so the Malaria Vaccine Implementation Project experiences. And to be frank, we drew on those experiences initially, and we continue to draw heavily from those experiences and the guidance from the countries that has come from the experiences. Indeed, today's three speakers will go into the rich details and learnings that continue to come out of Ghana, Kenya, and Malawi. And this is important because they've transitioned effectively from, again, project mode to broader program implementation, which is what's relevant for all the other countries that have ambitions to use this vaccine in their immunization programs in tandem with other malaria interventions. The task of designing this program and supporting countries to plan and prepare for vaccine intros and scale up really underlines the opportunities the malaria vaccine program presents to broaden partnerships. It's no longer the same usual suspects with whom we need to plan and coordinate, and hence the need to engage and work closely with a wider range of partners, specifically malaria partners, is essential. I think it's probably pretty obvious to everyone on this call why we need to do this. But just consider that the vaccine, like other malaria prevention measures, is only partially effective. So it's not just about introducing and scaling up the vaccine, which is what we're used to in the immunization world, but it's how and where do we do this? We need to consider the local epidemiology and transmission dynamics, demand for and use of different malaria control measures, and keep in mind the availability of resources and value for money, of other malaria interventions. This continues to play out in a number of different ways. At the global level, in terms of collaboration and active discussions between Gavi, the Global Fund, the President's Malaria Initiative, and our partners at Rollback Malaria to determine how best and how most effectively we work together for the benefit of comprehensive malaria control in countries. The corollary of this is also fundamental, and that has to do with successful introductions and what we're trying to achieve here. So we need to ensure that there is strong coordination and communication between NMCPs, National Malaria Control Programs, expanded programs on immunization. This is absolutely essential for appropriate planning, which is arguably more complex than other vaccine introductions. And with this comes lots of opportunities that we, of course, want to profit from, but there's also risks that we need to take into account as we're doing our planning and programming. This complexity underlines the importance of strong planning between, as I just mentioned, the NMCPs and EPI. And this is really to ensure readiness and preparations ahead of intros. But we've seen, subsequent to the MVIPs, in the early introductions, that the high demand for the vaccine at a political level, which we absolutely want because it is an indicator of demand, sustainability of programs, but it has gotten in the way at times. It's actually shaped the timing of introductions, and it has the ability to create risks that programs have struggled to respond to and to contain. With support for vaccines to be rolled out in national immunization programs, we also have the advantage of being able to leverage those existing systems. This usually has to do with, again, not always, but usually fairly established delivery, logistics, and data systems, and along with what we've witnessed. And that's really the unprecedented demand and community enthusiasm for this vaccine. So while this is a prime opportunity, if it's done effectively, we can then strengthen other components of essential immunization programs, and even potentially other components of broader primary health care. And yet at the same time, for us to consider is the fact that with the use recommendation that we have for the vaccine to be prioritized in moderate and high transmission areas, what that means is that a routine vaccine as part of EPI will be rolled out subnationally. This brings with it its own complexities and challenges for programs in terms of communication and planning. This is not typical. So this program is complex. It has lots of contrasts. It also has lots of opportunities for us to try to leverage, to try to strengthen our immunization programs, and as I mentioned, broader PHC. But it comes with risks. And it really underscores the need for strengthened planning and coordination, both at the global and country level, to ensure that malaria vaccines, as an additional prevention tool, are effectively and efficiently rolled out in countries. And with that, I'm really, really excited and looking forward to hearing the experiences from colleagues in the subsequent presentations to follow. So I'd like to once again thank the organizers for the opportunity to join you today. I will, of course, stick around for the presentations and looking forward to as well the question and answer session that will follow. Back to you, Benjamin.
Thank you very much, Dr. Stephen, and we really appreciate your thoughts and setting the stage for these sessions and the important points you raise about collaboration and coordination, which is very important, acknowledging that the malaria vaccine is partially effective and we still need to harness the other malaria prevention and control interventions. But importantly, how do we work together to ensure that the vaccine rollout works for everybody? And I guess those are strong points that you raise. And of course, many countries already have EPI systems. How do we leverage what's already in place to make sure that the vaccine reaches those areas that are in moderate and high transmission spaces? I think that those are important points that you bring up. Thank you so much, Dr. Stephen, for those introductory remarks. We shall be following on with a session from Dr. Isaac Mugoya, who is a senior immunization technical officer with the JSI. Isaac is also an epidemiologist with close to 20 plus years experience in immunization programming at national level. And just before he joined JSI, he worked for the Kenya Ministry of Health and held different management positions, including being deputy head of the Kenya Expanded Program on Immunization. Isaac, provides valuable technical support to the National Vaccines and Immunization Program and actively participates in regional work groups for immunization. Currently, Isaac is the country director for USAID's Momentum Routine Immunization Transformation and Equity Project. He has worked as an immunization technical advisor on several projects implemented by JSI in Kenya, including the USAID's Maternal and Child Integrated Program and the Maternal and Child Survival Program. Importantly to note about Isaac is that he was the lead in HPV introduction support by JSI in Kenya. Isaac will be taking us through two key areas. One is, what do we know about successful vaccine introduction? About 5 minutes to do that, Isaac. And then this will be followed by how do we adapt these lessons for malaria? What makes malaria unique? So Isaac, you're welcome to share with us your views about these two areas. And I hand the floor over to you. Thanks, Isaac.
Thank you, Benjamin. Could we have the next slides, please? Yeah, thank you for this session. I'll try to be as brief and as quick and as brief as possible. First, I think what you need to understand about the vaccine introduction, and I really appreciate what Dr. Seth has said, it's usually a multifaceted health, financial, and social undertaking. Many times we think it's just a health issue, but many of the challenges that come with the new vaccine introductions, many of them tend to be also social issues, social challenges that we need to address for vaccines. Any successful vaccine introduction requires proper planning, and this has to be country-led. Specifically, has to be led by the Ministry of Health. For two main reasons. The government is the only body that can coordinate everybody. who is a partner in the vaccine introduction. Number two, country leadership provides ownership and also provides a sense of sustainability of the program. A new vaccine introduction require partnerships and collaborations. Different partnerships and different collaborations will be required for different vaccines. Some may require collaboration within the partnerships, immunization partnerships, but as we move towards life course vaccinations, we will require partnerships beyond immunization fraternity with other health programs that really deal with the target populations that we're looking at, and also that deals better equipped than EPI programs to do the work of some of the works that the program may not actually require, may not be best suited to do. A new vaccine introduction requires a clear evaluations of the vaccine introductions. We are not just looking at the uptake of the vaccines, we are also looking at the impact of the vaccine introductions on disease morbidity, mortality, and also economic well-being of the people, the society, and also the countries. And some of these evaluations may not actually be possible to be conducted by the EPI, would require efforts outside the EPI. We need people with experience in surveillance, people who are health economists, who can be able to tell us the impact of the new vaccines. Of importance, and it's important for us to note, especially as today we are talking about malaria vaccines, any new vaccine introductions provide an opportunity for the immunization program to strengthen the immunization program and also build the capacity of the health workers. When I talk about the capacity of health workers, I do not want us to limit ourselves to the technical capacity in terms of the scientific knowledge of the vaccine and how to administer it and how to assess the immunization program. But of critical importance is to build the capacity of the health workers to be advocates for the vaccines. They are the ones who are on the front lines. They are the ones where the community usually come to ask questions and clarifications. So we must build the capacity of the healthcare workers to be able to respond to these questions in a manner that creates trust and also deals with myths and misconception. Next, please. The other thing that is important for us to remember about a new vaccine introductions is we need to be very clear and very consistent with the communications. And this entails some of the following. Our communications for the new vaccine is not just to create awareness, but must be aimed at creating trust. So the strategies that we employ for the new vaccine introductions must be strategies that are able to answer questions of the communities and the individuals and create trust in the vaccine program. We are all aware of the issues of hesitancy that quite often are fueled by myths and misconceptions and disinformation about vaccines. And these are some of the things that we have to be proactively thinking about how to tackle. We need to be multi-pronged to be able to segment the different audiences. And this will be able to help us to be able to segment and target our communication efforts, to be able to reach different
we are going to
audiences
need to make a request
through channels that are
Agnes
able.
told me that the pickup is in the garage.
There's some background noise, please. So we need to be clear.
Winnie, can you please mute? Go on, Isaac.
We need to have a clear communication objectives, and our objective must be informed by existing knowledge, attitudes, and the practices of our audiences. It is becoming increasingly important for us to gather these data before any vaccine introductions, because usually these are the things that hinder successful introductions. It requires recruiting services of credible organizations and individuals, if necessary. We have to be aware that when the people, the community are doubting the health authorities, there are people they still listen to. These are the ones that we need to recruit their services when communicating. And it is critical that any new vaccine that comes has to link with the existing program. The reason for this is that the existing program are there in many of the countries. They have been there, they have functioned well. So when you link the new vaccine with the existing program, you sort of ensure that there's continuity in that vaccine introductions. And number two, we try to ensure as possible that it aligns. It may not be all the time that the new vaccine would completely align with the existing program, but that is also an opportunity for us to be able to adapt the new program to the current reality. And finally, a new vaccine production have to be considered, and even communication for the new vaccine has to be considered within the life course vaccination approaches. For two reasons, some of these vaccines that are coming are being administered beyond the traditional 1 year. And number two is that as we introduce new vaccines, there are lessons that we are learning, and we need to use these lessons and opportunities to be able to have catch up for the other vaccines that we have a challenge with. When we have new vaccine, we have new strategies for life course vaccination. Next, please. How do we adapt all this experience to the introduction of a vaccine, a malaria vaccine? Next, please. Some few thoughts. I think I just picked three, and this will be my last slide. One, it is critical for collaboration between health programs. Specifically for malaria vaccine, you're talking about the EPI and National Malaria Control Program. And not just between the two programs, also between their partners that oppose those programs. Because this will help to ensure that vaccines there is a good uptake. If there is collaboration for EPI and malaria program, malaria programs can advocate for vaccine uptake as one of the malaria control interventions. They may not necessarily lead the administration of the vaccines, but they can play a part in advocating for uptake. In their communication materials, they can also include vaccine as one of the interventions for service delivery. On the other hand, EPI program will be able to manage and deliver vaccines that malaria program is not delivered. But again, in their communication, they should be able to raise the need of using other malaria control interventions as we give the vaccine. So in this way, you'll find the two programs would play a complementary role. The second thing that we can adapt for malaria vaccine is the integration of the new vaccine into the existing schedules. For most of the initial countries, I think the malaria vaccine being given in 4 doses, 2 of those doses actually could fit within the existing program. So instead of introducing 4 doses, 4 visits, we only introduce 2 visits. The 2 extra visits can also be used to strengthen the existing program by providing an extra opportunity for catch-up for other vaccines as well. And finally, I think it is critical for all of us to understand that not all programmatic requirements for a new vaccine introductions may be met by a single program. EPI program may not be able to handle all the aspects. They may not be able to handle logistics and administrations, as well as surveillance and evaluations. So we require all these other partners, and I think has been excellently demonstrated when we had several expertise from different organizations working on malaria vaccine introduction. And I think these are some of the lessons that I would propose that we can take home when you're thinking about the malaria program. I think that's my last slides. Back to you, Benjamin.
Thank you very much, Isaac. That was great, and we really thank you for those key areas that we need to take note of, and more especially planning and coordination, making sure there is clear and consistent communication, especially from trusted groups of individuals or organizations, and some of the lessons that we need to adapt. And I like it when you say that partnerships are beyond immunization. This will certainly, bring on board, I guess, the private sector and other players in the health field. Introducing new vaccines is really not an easy thing. I like it when you clearly indicate the need for a clear plan on evaluation of introduction of the vaccine, its uptake, its impact on disease morbidity and mortality, and the progress that's being made following the introduction of those vaccines. I can't agree with you more. In fact, consistent communication is really important, especially with the ongoing challenges and the new vaccines that are coming in, COVID-19 and all that has been talked about, some of the vaccines, and really recruiting services of credible organizations or individuals is of critical importance, especially when we go into new areas like this. So thank you very much, Isaac, for those key highlights. We are now going into looking at the real work done in some of the countries where this vaccine has been introduced. So we are looking at turning it into practice, all that has been talked about, and lessons from the malaria vaccine implementation program in Malawi, Ghana, and Kenya. And to help us get to know what happened in those countries, we have our colleague, Hannah Awusi, who's a public health specialist with close to 30 years of experience in several preventive health portfolios held in the Ministry of Health in Malawi, and JSI as an immunization advisor, where she has worked on a new vaccine introductions, data quality improvement, community mobilization for immunizations, improving health systems, development and implementation of policies and programs. Hannah comes to us with a master's in public health obtained from the Kamuzu University of Health Sciences. Hannah will be taking us through the overall introduction of the malaria vaccine in these countries, focusing on surveillance and monitoring, and looking at other aspects of the introduction process in these countries. Anna, the floor is yours, and we welcome you to the floor.
Thank you so much, Benjamin. Yeah, indeed, I'll be sharing some of the lessons that we learned in Malawi as we're implementing the malaria vaccine implementation program from 2019. This slide. So the first lesson that I'll talk about is the collaboration between EPI program and the malaria control programs, and of course, other technical partners that supported the MVIP. So as mentioned by both Stephen and Isaac, collaboration between these two units of the Ministry of Health is really important. We know the National Malaria Control Program comes into the malaria vaccine because of their interest in the control of malaria, and the EPI program comes in because they are the champions for delivering the vaccines in the country. So we really need both to work together for the success of the introduction of the malaria vaccine program. This means them to work together from the beginning, before the introduction, as they're identifying the areas, then during the introduction itself, and even the post-introduction period. These two need to work together. And of course, the engagement, effective engagement of the technical partners is also really key. So that in Malawi, this collaboration was really good. And no wonder we didn't have any confusions and even challenges with the MVIP. It worked very well because of their good collaboration. Next. The issue of good quality data is really of paramount. Stephen mentioned that mostly with malaria vaccine, you have to implement in areas with moderate and high priority burden for malaria. So that means you need data for you to determine this. And also from the immunization side, you need to decide the districts that have good performance, at least to know that these people can handle the immunization for a unique immunization vaccine like malaria. As such, you are guided by data for you to know the districts, and also without that data, and if the data is not of good quality, definitely you make wrong decisions. So starting from the beginning, people need to look into issues of data quality so that you are able to use that data. It's data that's really meaningful for you to make a decision. Next slide. So when we started the MVIP, we had challenges with the coverage. At the beginning, it was really low, and we're not surprised because this was through the misinformation that came in through the social media, and that really led to the vaccine hesitancy. And no, we're not surprised that we're having low coverage, as most people refuse to get the vaccine at the beginning. But with continued mobilization of the communities, as time went by, we saw an increase in the coverages. Like from 2020, at least there was an increase in the, like for dose 1, dose 2, and dose 3, there was an improvement. But honestly, we had challenges until now with the MV4, which is given at 22 months. Rather, this is not strange because at 22 months, it means we are now talking about the second year of life for this child. So we have challenges with the delivery of strategies for second year of life. So the lesson is that when you're introducing the malaria vaccine, because of dose 4, which comes in the second year of life, we need to strengthen the strategies for second year of life so that we also have higher coverages for the MV4. Next. Next slide. Yeah, so that slide is showing the charts, the trends over time from 2020 up to 2023, where you can see the orange graph being so low, and that's for the MV4. So as I was explaining, that's how low the coverage is for MV4 is. And at least you can see the other 3 doses being around 70s, even up to 90s. And there's been an increase over the years, although in 2023, we are seeing we saw a kind of a downward trend, which has peaked in 2024. Next slide. Next lesson is about the issue of additional visits to the immunization sessions. The sessions for malaria vaccine in Malawi are outside the other childhood vaccines. As you can see in the bottom row, the one that's highlighted in beige, you can see that all the doses for MV are alone, separate from the rest of the vaccines. So you can see malaria vaccine dose 1, which is given at 5 months, dose 2 at 6, dose 3 at 7, and dose 4 at 22. These are completely new visits that are coming in on top of the rest of the visits for the rest of the antigens, as you can see from BCG up to MR. These are alone. So it means we've added 4 completely new visits to the existing 6 visits, making 10. So this is also more often because of the additional visits. So this can also be one of the factors that's contributing to the low coverage for our malaria vaccine compared to the other vaccines like the measles, rubella that we have in our schedule. Next slide. Yeah, so that chart is also showing the trends over time that you can see for the MV1 and MV3. They are somehow at the bottom as compared to the to Penta3 and MR1, which are around 70s and 80s, but the MVs are around 50s and 60s. So we feel maybe it's these additional visits that are presenting a challenge to our caretakers to be coming for all the visits. Maybe they would start and on the way they would stop because it's like they're tired of coming to the facility more often. Next slide. Next. Yeah, so, but all the same, we need to educate the masses, we need to educate the caretakers about the advantage, the importance of the malaria vaccine in prevention of malaria. Although, yes, there are more additional visits, but at least they should persevere and still come. And also, where possible, countries should consider adding these malaria vaccines to the already existing schedule rather than introducing new visits. The other lesson is about the inequality in the provision of malaria vaccine. As mentioned by Steve, that the vaccine is not provided is only provided mostly to the moderate and the high priority areas. So the other areas that are seen as not being high priority, but still more, they do have malaria cases for children, they feel it's like they've been sidelined. They're not being given the vaccine, which is life-saving. So it was the same in the country. There was high demand for the vaccine, even from non-interventional areas. And remember, during the MVIP, even within the same district, you would have some facilities providing the vaccine and others not providing the vaccine. So most parents in the non-interventional areas really complained because they also wanted the vaccine. And thanks that now we've expanded even into those non-interventional areas, and no wonder we are seeing an increase even in the coverage. So for the countries that will be introducing the malaria vaccine, if possible, consider countrywide introduction of the vaccine to avoid this inequality which is there. And also sometimes we may want to look at the data just for the target population within that interventional catchment area. But where you are segregating, you are not giving others, they would still find their own ways of coming in to get the vaccine, and it becomes difficult to manage the contamination. Move on. Next slide. The other lesson we had was on the lesson of risk communication and community engagement activities. As I said, we had interventional and non-interventional areas. So because of that, the country did not implement mass communication activities. They were only restricted to the area, to interventional areas, and mostly they were just interpersonal communication activities. So as you know, IPC activities, it's difficult. You can't reach every community with the IPC activities. As such, there were some pockets within the communities, even within the same interventional areas, where the knowledge gap existed, because now they were only relying on the health workers to go around and talk to them about the vaccine, which is difficult at times. Yes, we have community health workers, but they couldn't visit each and every community. So this created some loopholes in the communication for the malaria vaccine, especially at the beginning. Let's move on. Yeah, and the last lesson that we've seen is the power of supportive supervision. With all those challenges that I've mentioned, the country kept on, especially the national level, kept on supervising the lower levels, like the district and the health facilities every quarter. And this really worked because the health workers were being mentored during those visits, and by and by, over the months, we could see the improvements in the delivery of the vaccine by the vaccinators as the mentorship was being provided during the visits. Thank you so much. Those were the lessons that I wanted to share from Malawi.
Thank you very much, Hannah, for those lessons that you picked from the actual implementation of this malaria vaccine. You really brought up very important components of the introductory process, lessons that have been learned from the work that has been done in those countries, collaboration between the different programs, malaria vaccine coverage. But of course, of interest is the data that we presented in terms of MV1, MV2, MV3, MV4. I guess during the discussion, you'll give us some highlights on some of the contributing factors to those. I know you did mention some of them. The importance of support supervision conducted by both national and district level supervisors. Again, we probably, as we go into discussions, will, try to explore the role of some of the community-based organizations, including community health workers and VHTs, in promoting these vaccines. Our last speaker, our last panelist, not necessarily the list, is on supply chain. Certainly with immunization program, supply chain presents a challenging part of logistics to fulfill the demand for the commodity that we are introducing. And to take us through this component is Ms. Wendy Prosser, who is a senior technical advisor currently at JSI. She's an accomplished global health professional with over 20 years of experience in vaccine supply chain optimization, health program design and management, cold chain management and maintenance. She excels at bridging technology and common sense to improve supply chain efficiencies, working together with key stakeholders to ensure the context is considered when designing supply chains and programs. Her work, Wendy's work, has focused on programs related to HIV, malaria, family planning, and vaccines, and the supply chains that support them. For more than a decade, she has focused on the immunization supply chain, putting the logic back into logistics, as she likes to say it, putting logic back into logistics. That's a nice one. Since being a Peace Corps volunteer in Cape Verde, this experience has taken her to a variety of countries, including Mozambique, Malawi, Angola, Kenya, the Democratic Republic of Congo, Pakistan, Tanzania, and Niger in various public health settings. Ms. Prosser holds a BA in literature, an MPA in international development with a specialization in global health from the University of Washington. Importantly, Wendy is very fluent in Portuguese, so I guess as she presents, if we have any members on the team who speak Portuguese, you can put in one or two Portuguese words to make sure they understand some of the context. Over to you, Wendy. We are glad and you are welcome to share with us the logistics side of the introduction of this vaccine. Thank you.
Thank you very much, Benjamin. And this, the few things that I want to point out are really just complimentary of everything that Isaac and Hannah have already talked about. If you move to the next slide, the first is kind of the global perspective of right now we are targeting high priority areas, right? Because there's not enough vaccines for everyone around the world. So this is going to require some thoughtful planning for rolling introduction with those high priority areas first. There's also it's going to require a bit of a more agile supply chain. So vaccines can move around as necessary between countries or even within a country. A lot of this was experienced with the COVID vaccine, that it was a slow startup when the COVID vaccine became available. So there was a lot of constraints in the supply chain, had to prioritize, had to plan accordingly. Can't say we did the greatest job of that across the world, but there are some great lessons learned that we can take from that. One of the key ones is the close monitoring of stock and the issues and expiration dates. And then this agile supply chain where things can move around if necessary. And then at the next slide takes us to more of the country level and what's happening there. And because it's going to be tailored introduction to high priority areas, that's going to have one implication for the planning and the forecasting planning for the country, where you have to actually dig into those specific areas for planning out the vaccine need and the quantity of vaccines that's needed. And one thing that people often bring up is the need for cold chain for vaccines, as we all know, is a requirement. There are tools that exist to conduct this analysis for a capacity assessment. What is interesting, that I find very interesting across a few countries now, Analysis shows of the capacity utilization rate of cold chain equipment is that at the facility level, more than 70% of the cold chain equipment at the facility level are using less than 10% of their space. It means you have a box this big, a cold chain, and you're using this much with the normal EPI schedule for vaccines. So it's an indication that there is sufficient capacity often if everything else in the supply chain is functioning. So you are getting your deliveries on time. If you're doing your quantification and your resupply decisions based on actual data that, again, as Hannah pointed out, is not always accurate. But I guess what I'm trying to say here is like, we don't need to go out and buy a bunch of new equipment, because proper planning of the supply chain and management of cold chain equipment and delivery frequency can actually make the supply chain stronger and use the equipment that's available. And I know as countries are preparing to introduce this vaccine, everyone's gearing up and looking at these types of analysis of the cold chain and the supply chain and what's working and what's not working. And really this point of having proper quantification and resupply decisions and analysis done based on those high priority areas is going to be an important part that the technical working groups can do. Thank you.
Well, thank you very much, Wendy. Thank you so much. We really appreciate it. Thank you, colleagues, for the excellent presentations and sharing your experiences about the introduction of this new malaria vaccine. I know we have some questions in the chat. I will want to start with a quick one here, and I think this will go to Stephen. What are the risks involved in taking the malaria vaccine, if any, just to start the discussion? And then I'll ask Sarah to help me with the other questions in the chat. So Stephen, if you are still online, do you have any?
Yeah, Benjamin, I'm online. There was actually, if it's okay, is my camera on? I think my camera's on.
Yeah, sure.
Yeah. There was actually another question that preceded that one, Benjamin. So I'll tackle the first one, then I'll come back to the safety question. The first question asked, it said the malaria mortality is highest among children under 5 years, and especially after 6 months. And the question is, why is the vaccine given to children at 5 months? So again, it's important for folks to understand the recommendation from WHO is that the first dose of the vaccine is provided to children starting around 5 months of age. So it's not completely prescriptive, but children can start the vaccine around 5 months of age. They shouldn't start it before, and they're not recommended to start it much later than that. And again, this is the first dose of a 4-dose schedule. And the 4-dose schedule is really designed to try to provide the best balance between the vaccine efficacy and, of course, the operational considerations that coexist alongside all of the vaccines that we're trying to implement. So again, aligning with other vaccines has already been presented in an earlier in one of the earlier presentations. It's important that, especially in that second year of life, that 4th dose try to be aligned with another touch point, such as second dose of malaria-containing vaccine at 15, sometimes 18 months of age. Some countries have decided to do it differently, and they've given justifications. But I think the point here is that, again, it's still a new vaccine, so there aren't like hard and fast prescriptive recommendations in terms of the timing of those doses. So that first dose can happen. We've seen most countries choose to implement that first dose at 5 or 6 months, but I believe there's one country that is starting at 7. And then it's usually given with at least 1 month intervals following that first dose, with the last dose, the 3rd dose of the 4-dose series, usually aligning with MCV1 at 9 months of age. With regard to the safety question, again, remember that the vaccine has been licensed. It's gone through all the requisite clinical trials, so efficacy and safety. It's been licensed as well, and it has gone through WHO pre-qualification. So, by any bar, that's a pretty high standard, by which we always want to know that it's been done. And I think we also understand that, there is a higher bar for biologicals, so vaccines than for other medical therapeutics. But I think we also, again, if you're from the immunization world, you also understand that all vaccines, including other medical interventions, do come with potential risks associated with taking them. And this vaccine is no different. There are adverse reactions, most of them mild, that can occur, ranging from pain at the injection site, fever. There can be allergic reactions. There can be more severe anaphylaxis that needs to be taken care of in terms of being able to make sure that we monitor that directly following vaccination. But again, in general, given the burden of malaria, given the risks of disease transmission, the estimation has been made that this is well worth taking into account some of the minor risks that are there.
Thanks, Steve. Thank you very much. I have another question here. This is for all the panelists. What are the implications of the malaria vaccine on prevention, control, and treatment activities? Is this something that we can have a quick response to? Whoever would like to go first. What are the implications of the malaria vaccine on prevention, control, and treatment activities? Are people going to hold back and say, after all, I've got a vaccine and therefore, I don't have to go for treatment? Is this going to...
Benjamin, I think it's important to hear from our country level colleagues. I think it would be good to hear from Hannah, if possible, and Isaac, if he's still on.
Okay.
I know the reports that I've read at the global level that bring together a lot of the data, and it's shown that the vaccine did not lead to any lower rates of usage of ITNs and other anti-malarial prevention measures. But maybe again, the country experiences are more important.
Yeah. Thanks, Steve.
Yes, actually, let me just add on to that, the vaccine is not a magic bullet, as we say. We need the rest of the malaria control, preventive measures. So what we've seen in the country is that as we're increasing the coverage for malaria vaccine, we are seeing people still continuing with the rest of the preventive measures. And even the National Malaria Control Program, it has really continued strengthening the rest of the preventive measures, including the treatment and alongside the vaccine. And no wonder we are seeing the impact now that we are seeing a reduction in the severity of malaria cases. Although I don't have the actual figures with me, I would have shared that, but at least we are seeing the impact, which shows at least that the malaria vaccine is also contributing to the prevention of the severe malaria in the country.
Thanks, Hannah. For the next 3 minutes that we have, I'll quickly go through some of the questions that probably would need quick answers for. And one of them is, what is the efficacy of the vaccine if not all the 4 doses are administered? Do we have any data on this from a practical perspective in the 3 countries?
So I can speak to what I know, and then maybe some of if the other country level colleagues want to come in. The vaccine, and again, let's all keep in mind that this is it's still a new vaccine. The RTSS vaccine, of course, we have a lot more experience with RTSS than we do with the second vaccine that's come along, R21. But the 2 vaccines are of similar construct, mechanism of action. And so, again, in making the determination that WHO made in terms of its pre-qualification, there is some assumption that they will behave similarly in the field. And what we don't have are head-to-head studies that look at the comparative efficacy between the two vaccines in the same transmission dynamic areas. We've seen, again, higher levels of vaccine efficacy in areas of seasonal transmission when doses are provided, both either as part of, say, age-based routine immunization or as part of seasonal dosing strategies, meaning that dose is timed just ahead of the high transmission season or the perennial peak of transmission. And in those areas, vaccine efficacy is around 70%, between 70 and 75%. And so, again, I think the point that also Hannah was making, this is an additional tool. It's definitely not a silver bullet, right? And we have to be really clear at all levels, at the global level when we're talking in such webinars as this one, all the way down to the operational level when we're talking to frontline healthcare workers, to ensure that they understand that they're passing on that same communication to mothers, caretakers, and families, that folks still need to continue sleeping underneath bed nets. They still need to be using SMC if they're in seasonal transmission areas. Programs will still continue to try to use other vector control methodologies if it's appropriate in those areas. So let's think of this as, again, we have a toolkit that is strengthened with the advent of vaccines. But again, it has to be used in coordination with each of the individual interventions.
Right, thanks, Steve. There are quite a number now. We are up to the 5 o'clock schedule that we had for the meeting today. There are quite a number of questions in the chat. Susan, I don't know whether we can pick these questions and send them over to the panelists. Yeah. And then we try and get some of the responses, because I'm not sure we shall have the time for all of them. Just a quick one for Wendy. Does introducing the malaria vaccine introduce any unique challenges for the supply chain? How does it compare to other introductions like rotavirus and the other vaccines that have come up?
That's a great question. It can be integrated into the regular vaccine supply chain because it uses the same cold chain temperature requirements of 2 to 8 degrees. The couple considerations is this specialized tailored quantification forecasting for these high priority areas. So that part can't be incorporated into the national level planning for vaccine needs. So that's one consideration, but otherwise it should be included into the regular vaccine supply chain and cold chain. Thanks, Vincent.
Thank you very much. Thank you very much, colleagues. Certainly we have a lot to discuss. We have a lot of questions here that have come through. Unfortunately, time is not on our side. It's not our best ally. I'd like, on behalf of the team again, to thank our panelists for the excellent presentations and the response to the questions. And to all of us who have participated in this webinar. This is the first of its kind. Certainly we will have several of these. I would like to very sincerely thank the Center for HIV and Infectious Diseases at JSI for organizing this webinar and for allowing me to be part of this process. To you all, thank you again. Let's look at what this new vaccine brings on board. And certainly it's an important tool as we fight malaria in our countries. So with that said, unless there is any other comment from colleagues, Sarah, if you have 1 or 2 things to say, I'll ask you to say them. Otherwise, from me, have a good day and a good evening for those in the areas this side of the Atlantic.